Good afternoon, everyone. Welcome to the second of our free forums, Telemedicine Now and How, made possible by a grant from the California Healthcare Foundation. Today's theme is Modern Palliative Care in the Context of COVID-19, Expert Q&A on Symptom Management and Patient Education at a Distance. The forums are presented by the CSU Shiley Institute for Palliative Care in partnership with ResolutionCare, pioneering telemedicine in Northern California. I'm Jennifer Ballentine, Executive Director of the Institute, and I'll be your moderator today. The CSU Institute for Palliative Care is a workforce initiative of the California State University system, offering online education in palliative care for frontline clinicians and healthcare organizations. And now I'll introduce our facilitators. Michael Fratkin is a builder, innovator, and dreamer who approaches life and the practice of medicine with love and respect. Incorporating principles of value-based payment, technology-enabled service delivery, and interprofessional team integration, Dr. Fratkin and his team have created ResolutionCare Network to build capacity for high-quality home-based palliative care in rural Northern California and beyond. Dr. Brian Mistler is Chief Operating Officer at ResolutionCare, a benefit corporation committed to leveraging telehealth technologies to deliver quality care to a racially, economically, and geographically diverse population, including large rural areas in Northern California. Dr. Mistler is a healthcare leader with a deep understanding of the strategies that drive business impact and individual change. And today we have a guest facilitator, Dr. Mike Rabow, who is Professor of Clinical Medicine at UCSF, board certified in internal medicine and hospice and palliative medicine. He leads the outpatient palliative care consult service. He's the past winner of the Hastings Center Cunniff-Dixon Physician Award, and full disclosure, a member of our National Advisory Board. So with that, Dr. Fratkin, Dr. Mistler, Dr. Rabow, take it away.
May I take it away? Okay.
Yeah.
So the first thing I want to do is I'm disappointed that Glenn Sigrid turned from a cat into a person eating his lunch, but I guess I can deal with that. Are there any other cats out there? Yeah, there we go. That's what we like. Now we want to see you, Glenn. In fact, we want to see all of you if you're brave enough to turn on your video. It'd be really nice. The beauty of this platform is that it's a two-way street here. This is not quite the same as sitting in a room together, but it's not a bad facsimile of that. So I'd like to invite any of you who wish, and I won't shame any of you non-video people excessively. But it does give me a chance to kind of scan the room and understand sort of what you all are up to, and when you're nodding or when you're nodding off, or if you need to not have the video on, it's okay, but I invite you to do that. This structure is designed to be open, in fact, wide open. While there's a topic that we propose, and I'll ask Dr. Rabow or Mike to just begin a little opening riff on the basis of that topic. Mainly, this is a back and forth exchange for us who've been doing telemedicine for palliative care purposes and understanding how to use telemedicine for any purpose, really, in a clinical engagement, to everyone out there who is rushing quickly to try and figure out what works, what doesn't work, what mistakes don't I have to make, if I can hear it from some folks that have some experience. So the large majority of this exchange is back and forth, question and answer, and also invite you to share your own experiences in this blisteringly fast, rapid adoption phase of telehealth in the context of COVID-19. Brian Mistler, do you want to add anything or say anything? Say hello.
I'll just say hello, and it's good to be here. And again, as Jennifer said at the top, we'll really inviting your questions, and she'll be looking for those via the chat window, and I'll be looking for your electronically raised hands.
And then in addition to all those wonderful things that Mike Rabow does and is professionally, he's one of the people that has helped me to understand what's possible in my field. He's my friend. He's been a teacher and a colleague. It's just a pleasure to invite him to kind of offer his unique vantage point on telehealth adoption. So take it away, Mike.
Well, thank you very much. It's super kind. I may have been part of a consideration about what was possible, but what actually has happened and what has been built is entirely due to Brian and Michael and all the people who have done such wonderful work building what they have. So it's great to see, literally to see folks, and it's an honor to be here. My ability to be at the top of this hour and do any introduction just comes from the fact that I'm one of the early adopters for Palliative Care. Our program's done a lot of telemedicine for our palliative care program at UCSF in cancer. And we've done a little bit of research on it as well. So I have some things to offer, but really looking forward to everyone's experience. I guess to really start off, the main thing that I would want to say is that I think that telemedicine is very much like a lot of things that are coming to pass during these times of COVID, which is that it's really not an either or situation. It's not better or worse than in-person care. It's really a both and situation. There are some things that are better, some things that people are discovering that they love, and there are some things that are worse or are harder that people are discovering make it really difficult. I think there's some evidence that communication itself is harder via telemedicine, that sometimes the video accentuates the difficulties or the weaknesses that we've had in our abilities to communicate. We sort of lose, obviously we lose an entire dimension, the third dimension. We lose a lot of our understanding of people's facial expressions, of their body language, and we lose whatever gestalt, intuition, and nameless things that we get from actually being present with someone in the very room with them. But we gain some incredible things as well, and I hope that that's what we're going to be talking about, that directly translate into the ability, I think, to impact patients, to understand patients well, and to provide education to patients. I think that for me, telemedicine has meant a very different clinician-patient relationship. It has been said that telemedicine starts to break down some of the hierarchies that we experience in clinical practice. That it's not a patient coming to, say, a doctor's office, or a doctor standing over a patient telling them what to do, that this is a technology that has really homogenized, or maybe the better word is humanized, the experience of relationship in some really profound ways. And I think that those provide a lot of potential for all of us. And so I'm pretty bullish about telemedicine, and I think we're all starting to recognize that as much as it was starting up before COVID, now in COVID, and certainly in the years to follow, telemedicine has a place in almost every health system now, and will continue to, and it'll be a part of how we care for each other, care for ourselves, and care for patients. So excited to participate in this discussion.
So Alyssa Tiller from Hope West submitted a comment that I think is worth sharing with everyone, that the advantage when everyone is wearing masks is that the patient can see your face in telehealth. And I'll just share that for me personally, that this is a huge advantage. I have a mild hearing loss. I wear hearing aids. And I tell my staff all the time, if I can't see you, I can't hear you, which may be kind of a dangerous admission, but it is very difficult when I am in a clinical encounter and the doctor or the nurse is wearing a mask. It makes it that much harder for me to understand what's being said. And I tend to just nod and smile and agree with whatever is being said, which is not necessarily the best strategy. So as many of our patients are older and may have, like me, spent a little too much time too close to the speaker stacks in the 70s, it's a consideration. So being able to see you speak is really an advantage. I'll go to some of the questions that were submitted ahead of time to start us off, kind of in relation to the theme. How can we rate patients' symptoms as to when they should report to the hospital when you're trying to do some kind of an assessment or evaluation through telehealth?
I'll take it and then pass it to Mike as well. It is remarkable how assessment can be performed via this technology. At least in a palliative care space, we're not the last one standing, right? There are other elements of the healthcare system, primary care practices, urgent care, acute care evaluations in the emergency department that lives with us. But I've been tracking quite closely over, well, these last 5 years that we've been doing this work, and certainly over the last 3 weeks, to how we discriminate when a person needs a different level of care or channel of evaluation other than through video. And thus far, we've actually done very well at being able to make an assessment based on the trajectory of illness, the severity of symptoms, their progression. And we're able to touch base with people, at least in our practice, sometimes multiple times per day by multiple different observers. So that allows us to track and maximally keep people out of acute care settings without feeling as if we have to take excessive risk in doing so. So that's kind of how we approach that. Go ahead, Mike.
Yeah, I mean, I think that assessment per se is very, very similar. Obviously, you can try and get some objective measures of patients' function and well-being using scales, a 0 to 10 scale as an example, or mild, moderate, severe scale, as well as obviously paying attention to changes over time. And those aren't necessarily different for telemedicine as they are for face-to-face medicine. One of the things that we actually use is we have paper or online paper-based scales that we use to supplement telemedicine. So before visits, people might fill out a computer-generated survey that then a clinician might have during the visit and be able to use that to reflect back to the patient how they're doing and be able to sort of trend symptoms over time. So telemedicine often won't be the only technology that you're using. Other ways of connecting with patients can play into telemedicine and can be a part of the telemedicine visit. So I think that it's very, very similar. We're missing the physical exam, although we often are able to do one part of the exam, which is inspection, quite well. You can zero the camera into a rash and take a look at the rash. The other thing that often can be helpful in assessment that we may or may not have during in-person visits is that there may be other people in the household who can be brought in to help make the assessment. So just like you might do in person, if there is a family member in the room, you can say, does it look worse to you? You can ask if someone seems more depressed than before. So you can do that as telemedicine as well, keeping close account for who's in the room, who the patient wants in the room, HIPAA issues, where children are present or not in the televisit encounter. But in some ways, we lose palpation, I guess, as part of the exam, but we do gain often other people's objective assessments as well.
What I'd just to add to that, or to circle back to something that Mike said, was that there's a leveling of the experience. The typical traditional clinical examination is a very passive experience for the person that you're assessing. They're just lying there while you poke them and listen to them and tap them and evaluate them physically. When you're doing it like this, it's actually a much more level encounter. They have responsibility to bring forward the information, and they're more able to learn to track their own findings over time, because it's they realize that anything I receive as to integrate into an assessment is their responsibility to bring to me. So it has that added engagement piece.
Sorry, Jennifer, to interrupt, but one other comment to again add on is the idea of additional technologies, and that programs that have the resources to be able to do this, or insurance plans that can organize this. There's all sorts of remote monitoring that is becoming increasingly popular and increasingly useful in clinical assessment, so that people who have iPhones and other smartphones, as well as other technologies that can be brought into the home, might be able to provide you with a lot of data. Dare I say, more data than you'd ever want. You can get your iPhone to send your doctor 1,000 pieces of data, or 10,000 pieces of data that they've been monitoring your heart for a month, that your doctor won't know what to do with it, or your nurse practitioner or other clinician. So getting blood pressures, getting heart rates, getting temperature, getting pulse ox, and potentially soon enough other parts of the exam are going to be increasingly common and available to those of us doing televisits.
So this is from Joe Quinn, and he says, I'm a volunteer chaplain. Do you see telemedicine working in the chaplain space?
So I'll just jump in because I have a quick answer, which is, of course, absolutely, it's already happening. The chaplains at UCSF, which is now essentially 100% remote within palliative care, and 90% remote otherwise, are doing all their visits remotely via telemedicine. We know this to be the case in hospitals currently across the country, where very few people are actually making direct contact with patients. Almost everybody is doing remote, and that includes our chaplaincy services. And that obviously protects people who aren't infected from getting infected, and people who are infected from infecting others. It saves on PPE, which is important. And for sure, I think that we all are cautious about the idea of doing really important things via telemedicine. But of course, that is one of the important parts of telemedicine. It allows us to do those important things for people who might otherwise not be able to have access to clinical help because of location, because of infection, whatever it is. We did a small survey of palliative care patients who received some telemedicine prior to COVID, asking about their comfort with it, their satisfaction with it, and specifically around their comfort talking about difficult subjects, talking about bad news, talking about spirituality, talking about emotional issues of deep meaning. And nearly 100% of people and caregivers really appreciated the opportunity to talk about even the hardest topics via telemedicine. So I really encourage all of us not to hold back on doing the difficult work that we do that's so important to patients, knowing that this is the place where currently in the world and in the future, a big part of the world is going to be interacting around even the most sensitive of topics.
Perfect. We have we had a question, and the hand just disappeared. If you still want to jump in, Patricia, I'm going to unmute you and give you a chance to ask your question, or you can wave off if you don't want.
Okay. Are you able to hear me?
Yes.
Awesome. Thanks. I have an observation. I do home-based primary care, primarily with a lot of older adults, dementia patients, folks who can't get to the clinic for their primary care visits. And what I've been seeing since we've started doing telehealth visits, telemedicine visits, is that it's very helpful for me as a clinician. I can lay eyes on the dementia patient Not that that dementia patient can always give me the report, but I get it from the caregivers. And here's the downside. The caregivers at either at home or especially in facilities are really being pushed more as a result of telemedicine. That's what I'm observing and experiencing. I mean, it takes a lot of their time to participate and to facilitate these visits. And I just wanted to share that observation and see if anybody else has seen that as well, and if they have any other suggestions. Thanks.
Dr. Fratkin or Dr. Rabow, do either of you want to start off addressing that?
I think that the population of folks that are not 100% cognitively intact are a challenge in all care settings, and particularly in the nursing home environment. We've engaged with our staff historically to facilitate these conversations. I think that's what you're referring to, is that staff are being asked to hold the device, or caregivers are being asked to facilitate the conversation, and that's an additional burden on them. Am I getting that right, Patricia?
Yes, that's correct. And I don't see folks in nursing homes. I actually see folks either in their homes or in assisted living or board and care facilities, which has even more, I think, challenges in that there are no skilled professionals in that setting. So thank you.
Well, no formally designated as skilled professionals. The caregivers in those environments are sometimes the most extraordinarily skilled people I know, and the best observers, right?
Good point.
Yeah, no, I think you speak to a challenge, is that there are people that really do need someone to hold the device, really do need that assistance in some environments, and programs just need to lean into solving those problems when they're present.
Yeah.
I recognize exactly what you're saying. I would just also add another potential opportunity that telemedicine provides around caregivers, which may not be the day-to-day caregiver who is definitely put upon to help facilitate this. But now increasingly we've got the ability to involve people who really care but are at a distance and may not be there day to day. I think many of us have had this experience personally. If you had an Easter celebration or a family Passover get together where all of a sudden your cousin from Des Moines you were seeing face to face, who you never would have celebrated with previously, but now you're having weekly check-ins with family who you never thought you'd ever meet face to face. So telemedicine actually allows people from all around the world to participate in a doctor's visit or nursing visit or chaplaincy, social work visit, which can be really, really meaningful for patients as well as for the caregivers, and a huge convenience. Literally, people who are at work can take 10 minutes out of their day to join an ongoing visit. So that's one advantage. But the burden on caregiver is absolutely true. It's clear. In our satisfaction survey, caregivers were even more likely than patients to say that they appreciated the ability to talk about sensitive topics via telemedicine.
Yeah.
So we have another question from the chat box. How does one overcome any culturally sensitive issues when the patient is transitioning from palliative to hospice care with the use of telemedicine?
I'll speak to it. I think I'll speak to it in more general terms. I think there are many things that we assume to be the tough dilemmas in transitions of care or in transitions of understanding where a person is in the arc of their illness, or tough family situations. And in those situations, it's more likely to be concerned that this technology or this platform or this channel for communication will fail us, because it takes everything we've got to do that at the bedside, to do that in the clinic, to do that in the hospital, to do that in the home setting. what I've discovered over the time of doing this work is that most of those obstacles evaporate with the bravery to step into the space to do them. We've done dozens of people who are outside the realm of even hospice availability. We've taken those people all the way to their death in the absence of access to all of the typical things that you would expect you need to have in hospice. The conversations related to when is the right moment to invite or at least learn about what a hospice model of care happens can happen really easily, and maybe in some ways even better through these technologies. Remember, again, you're not taking a person, forcing them into a clinical environment where they identify as a patient. What you're doing is you click a link, they click a link, and poof, just like all of you all are right where you feel most comfortable. And almost instantly we can enter into the framed conversation that's required. There's less distraction, there's less anxiety, there's oftentimes a dog or a cat, or if not a caregiver or someone that they love. Those things actually enhance the ability to really connect and communicate through the most difficult things, despite our kind of pre-existing bias that it might be harder to do this way. It actually turns out in many circumstances, like this hospice transitional conversation, to actually go more easily and more efficiently and more smoothly and more personally through this technology. That's my impression.
Yeah, I would completely agree with that. It goes back to what Michael described as the leveling or the breakdown of the hierarchy. In a telemedicine visit, you go from sort of being king or queen of your own domain in a health system to a guest in someone's house. And so there's the possibility, the opportunity for the cultural barriers actually to break down, because now you recognize yourself as going into someone's home literally, and as understanding that you're a guest in their home and in their culture. And the way you would if you recognize that you were a guest in real life, you might say something like, I don't know your ways. Can you help me know what I need to know to be able to be here, to participate in this experience with you all? Do you take off your shoes? Do you not take off your shoes? Are you allowed to say certain words or you're not? And so in a way, the transition to telemedicine, or the introduction to telemedicine that many of us have been going through, is a nice opportunity for us to go back and say, we need to learn the ways that our patients, how they live their lives, and we need to be humble about that and ask for permission more and understand better who the people are, what the home looks like, what the people in the home are like. And that in that way, I think that Michael's exactly right, that the frame of the clinical encounter in telemedicine really reminds us that we're bringing something and we're meeting people halfway, literally on this screen.
Okay, so one from the chat box again. This is it from Joe Quinn. I am also an IT project manager. Just yesterday, I was asked to organize and coordinate the rollout of telemedicine. How do I figure out the best practices and tap into other lessons learned? This is your
Mike,
cue.
that's my cue. Mike, why don't you go? Because I actually was reading the amazing chat box comments at the time. So just full disclosure, I didn't even hear the question. So you answer it.
Well, as it turns out, you and Brian may be the best suited to do this. I will just say very briefly, the question was about someone who spans the clinical and the IT worlds. How do you sort of roll out telemedicine? I think the first thing you do is make sure that you're not trying to make things up on your own for the very first time, because so many people, including Brian and Michael, really have such great expertise about doing this. UCSF has experience doing this, and many medical centers have gotten to a place where they've organized around how to roll out telemedicine. It's relatively easy to do. I think I would just say, before I let Michael and Brian comment, that the most important thing is convincing the people who you're working with that it's not a big deal. it's actually relatively straightforward and relatively easy to do. So I don't want to belittle the task of getting it going in institutions, but I've heard from so many folks who waited for like the perfect plan, you know, for a year or two, and then all of a sudden in 3 days, 2 days or 2 hours, they like got up and running. So this is very much, you know, a situation where the perfect can be the enemy of the good, and that it's literally not going to be as hard or big a change as you might expect. And I'll let these other folks talk about maybe a little bit more where you can get technical assistance.
Go, Brian.
Sure. Well, it's reassuring to hear. I was going to give exactly the same thesis, which is that the best technology is the technology that you have available today. And having worked in IT for a while, I understand all the very real concerns about project management and timeline and all the systems that need to interact that we would normally put in place for a long-term plan. I think it's right to be thinking about that, and I think we are talking about a long-term plan. But at the same time, there are technologies available today that can maybe be rolled out quicker and serve in a short-term way. And the amount of education that you think you need is not, the barrier to entry is so low, and people come with a comfort with some of these technologies that they might not with a specialized statistical package or a specialized EMR. People are used to using FaceTime and other things, Skype and Zoom in their own lives. And so the barrier to entry is so low, and the immediate need is so high, that my advice is exactly the same as Dr. Rabow's, which is do something now and improve it later, iterate rather than waiting for that perfect solution.
For sure. And what I'll offer is what you very likely already know, is that in the last 3 to 4 weeks, so many of the obstacles, regulatory obstacles, billing obstacles, policy obstacles, as well as perceptual obstacles, have all evaporated. So the space is now open for you and your institutions to rapidly adopt the use of this medicine without concerns about the HIPAA compliance of this or that platform, without the need to engage with a quote vendor for some proprietary video conferencing platform. Just to be clear for everyone, the federal regulations that would audit compliance with HIPAA related to what platform you use have been relaxed, so that you can use Zoom, you can use Microsoft Teams if you can figure out how to make it work, you can use WebEx if you can figure out how to make that work, you can use FaceTime, you can use Facebook Messenger, and you can use video and some of the proprietary ones, Doxy, ME. I don't even know how many there are. All I know is that they're at your fingertips. You've been given free rein to use them to connect directly in real time, audio visually with people, in addition to much more than usual use of telephone based assessment in a number of clinical settings. I think at the end of COVID-19, as if just like I hope that there actually is such a moment, on the other end of the peaked curve, the flattened curve, the regulations are likely to split. Some will regress to the prior normal. For example, I think that parity in use of telephone assessments will go back away. But I think that the video conferencing based engagement for clinical encounters as equivalent to or with parity on billing and I mean, there's the horse is out of the barn, the genie's out of the bottle, the toothpaste out of the tube. I'm open to any other metaphors, but I don't think we're going back in terms of allowing for video conferencing based encounters to appropriately persist as a part of the new normal going forward.
I'm going to add one more thought, which is that in IT project management, and in my experience, it's always so important for the technological folks to speak and understand the language of the end users and vice versa, and you kind of live in that middle world of trying to translate those two things. In this case, some of that's going to happen in real time, but I would encourage, I think the physical technology is going to be the easier part, and then it's helping make sure that both parties know how to speak each other's language. And so I'd encourage you to think about, I'll offer a shameless plug for the course that Dr. Fratkin and I are teaching through the CSU system. If you have folks on your team who you feel like you got the technology part and they want to dig in a little more deeply to understand how it's used, even if they're IT who want to understand the clinical perspective, you might encourage having a couple representatives join that class so that you can kind of develop, maximize, iterate, improve that technology over time.
I would also just add beyond government regulation, insurance companies, we also will have the reality of consumer demand. Now that people realize that they can stay in their PJs on an early Monday morning and have a doctor's visit and not pay $30 for parking, et cetera, we're going to be hearing from our patients and their families that they want to do video visits. Obviously, there are going to be times where you're going to want to see the patient in person. There's going to be times when the person wants to be seen in person and touched, and the benefits of all of that. But there's also going to be plenty of time where people are like, you know what? I have a 20-minute visit. I don't want to have to drive an hour to the doctor's office for that visit. So we're going to also have patient-family demand for thinking about all these visits with physicians, nurses, everybody on the team, I think.
Let me, and to keep going with that thought for just a moment, in terms of the forces likely to keep the toothpaste out of the tube, I want to ask, for those of you that are beginning to explore this, have any of you noticed that what you would consider to be a complete encounter is happening in less time? Have any of you noticed that? Nod so I can see you, folks. Yeah? No, yes, 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 yes. Maybe that one's asleep. I can't tell. Mike Rabow, are you noticing that for example, your initial encounter to meet somebody new as a physician, how do you think it's affected the time it takes to complete that encounter?
Yeah, so right from the very beginning of my experience with telemedicine, one thing I noticed is it's much easier to end a phone call or a video call than it is to get someone out of the room. If that's how you're thinking about it.
I appreciate that.
Excuse me for the expression, but literally, you know, how many of us have had those conversations where we're like, you know, we need to go. We're standing up by the door with the hand on the doorknob, like trying to communicate in every way that we know that the visit has to end because we have other things we have to do. It can be very, very difficult when someone is sitting comfortably in your chair. I think on telephone and on video, we're much more used to the fact that where we live, where we stay, where we are for most of the time is right here in our seat in our home, and that the clinical encounter is something that sort of drops into our life. And so it makes sense to understand it as being defined by a specific amount of time. And I think that there's something about that that just makes it easier for video visits to stay on time. I think depending on your technology, it may be even more important that they stay on time as well, because you might end up having your next patient waiting in the waiting room. And you don't want them to disappear from the waiting room. It's probably harder to wait in a waiting room telephonically or on video for 2 hours than it is when you're already parked and stuck at the medical center. So I do find that both the clinician and patients often are each of them much more aware of the need to accomplish the task in the time that you have. And maybe there's some analogy to therapy for anyone on our call who's ever been in therapy, where you're like, yeah, you got 5 more minutes. If you're ever going to talk about your mom, now's the time. Like, people get to it because they know that the time is going to end.
So returning to our theme of cultural challenges, we had a question come through about, this is from Francis Vining. I have several patients with whom I need to use a language line for assistance. How is this used with telehealth visits?
We have used it very, very effectively, either by video or by telephone. Video is better, actually, to have the nonverbal communication happening in the other language or in the first language. And it really, just like it is on the telephone line, is very operator dependent. Each translator is not equivalent to the others. There are a number, there's one called the Language Access Network that actually provides via their video platform, video-based translation as a service line into hospital environments around the country. It works, and it works better than a family member who's translating, because the dynamics of that relationship are often fraught. We do a lot of that too, just out of practical need. But I think it's a very appropriate question. There are ways to really bump the quality of that by using these technologies and connecting on-demand translation by video or by purely audio. I think for Dr. Rabow, I think in San Francisco and in the Bay Area, it's even a larger challenge with greater diversity than what we face up in rural Northern California.
Yeah, so depending on your service, you hopefully will have access to all the different languages that you're likely to encounter. And I would certainly, this is not specific to telemedicine or video medicine, I would really underscore the comment about how professional interpretation, professional translation is super important. I think we are so appreciative that, you know, the son or daughter is able to communicate in English, that we tend to inappropriately take advantage of that convenience. And what we sacrifice is really the family member's role as a family member, rather than calling them into service as our interpreters. But professional interpreters are good at what they do, and they're good at helping not just translate the words, but to interpret what's going on for you as well. So a little bit of a guide into perhaps a different culture than you yourself know something about.
So here's a question from Suzanne Weinberg. How does it go once you're up to speed with scheduling? Are patients or clients waiting by their computers as long as they wait in waiting rooms for those who see people in offices? Nice segue from the last question.
Maybe I'll just jump in just to continue my response. I think, so we schedule video and in-person exactly the same, but the system we work with tends to kick the person in the waiting room out after 15 minutes. So that's partly a motivation that I have to stay on time, is I know it's going to just add a hassle to the day to try and get people back online if they get kicked out. So I'm very, very interested in staying on time for that reason in particular. But we do have a waiting room function. And just as a side note, many of you have read about, or perhaps unfortunately experienced, Zoom bombing, the idea that someone not invited into the Zoom conversation comes in inappropriately and potentially spreads inappropriate content in your meeting. If you have in Zoom and in other platforms, you should definitely, I think, be prepared to prevent these kinds of intrusions for yourself and for the patient and their family. In Zoom, which is what we use at UCSF, if you have a personal ID, people who sign in to your personal ID automatically get put into the waiting room. So you maintain some control of who comes into the visit, which is useful for serial visits with different people. You keep, your 9:30 out of the visit until it's 9:30 and you're ready for them. But it's also a sort of built-in safety measure to make sure that no inappropriate intrusions happen.
Yeah, my experience has been that we don't use the waiting room function, and maybe because we don't even use that 15 minutes. Something about this form of scheduling and the agreements that relate to on-timeness, it just seemed that we're a lot closer. And for my people that are waiting for me at home for a minute or two, or sometimes even longer, I'll, if it's going to be a bit longer, I'll just have the care coordinator give them a call, just let them know. But they're sitting at home and they're eating cookies and playing with their cat and watching TV, and they're not sitting in some threatening environment where people are coughing and sneezing and all the People magazines are 10 years old and all the rest of it. So people are a lot happier to be, to tolerate a little bit of tardiness. But I have to say that the technology itself and the nature of scheduling this way seems to keep me way better on time than I ever used to be. Are others having that experience too? I see Mike nodding his head. There's just something about it that makes it a little bit more on time.
Susan, let's see if we can hear you. You can try asking your question.
Okay, can you hear me?
Perfect. Yep, go ahead.
Okay, so I was just wondering whether there are concrete suggestions for establishing rapport in a medium that's by necessity a little bit more remote. I'm a chaplain, so that's really important.
Mike, you go first.
Sure. So I think it's a great question. And I think establishing rapport and engagement are really some of the biggest advantages that we would talk about. I think that some of the things we can do to help maintain or establish rapport are technical. I think that the clearer the video is, the better the lighting, the less distracting the background is, probably the better. You know, people can get nauseous looking at someone who's holding a video camera or telephone themselves. So thinking about the technical aspects can be very, very helpful if you're not too far away from the screen, if you're not too close to the screen. I think the other big issue that is very, very key to this is about eye contact. And so having people look into the camera is very important. The camera that you're using may not be close to where the image of the person is. So to whatever extent you can move the image of the person that you're talking with closer to where your camera is, that works better. And then you have better eye contact. I think technology is going to solve this problem. There's probably some apps that do this already to sort of correct for the fact that you're looking at the top of your screen, but their image may be in the middle of your screen. So I think that those technical aspects are important. I think eye contact is important. I think body language is important. So one of the things that I've learned to do is to sort of accentuate body language when I'm on clinical visits with people, so that if I'm greeting them, they can see that I'm saying hello, but I'm also waving my hand. You know, I make my nods a little bit bigger, my smile perhaps a little bit bigger, although maybe that's not possible, I don't know. So, you know, I think there's these technical ideas of how to increase rapport. I think that the other part of it comes a little bit more naturally. I think people feel a little bit more comfortable when things are a little bit less formal than in the structured sort of hierarchy of a health system, perhaps. So that if you're doing telemedicine from home, I think it's okay for people to see, you know, your ceiling or the color of your wall. And notably, I think that when you see something very personal in someone else's screen, I think it's okay to note that and to let people know that you're touched by having had that experience. The example I give is from a call that I had a while ago, which was someone who was quite ill. They were in their night clothes, they were in bed, they were under the covers and talking to me from there. But in the background, off their shoulder, were the photographs on their nightstand of the people they loved. And so it was an opportunity for me to say, wow, those are amazing pictures. And then an opportunity for the person to tell me who was in those photos. And that made it incredibly personal. I think of it as the sort of telemedicine equivalent of when I'm doing a cardiac exam and someone has a religious symbol like a crucifix on a necklace above their heart, and I have to move that out of the way to do the exam. I never just sort of flick it out of the way without mentioning it. I always would say something like, oh, is it okay if I move this out of the way, or how beautiful that is, or where's that from, or something. These kinds of connections that really go towards deepening the intimacy of the relationship.
For sure, for sure. Thanks, Mike. You know, I would add to it too, just at the very beginning, I speak to and acknowledge the nature of that this is an unusual and probably even more new for them than it is for me. What I found is that when things aren't quite right, or if the connection's wrong, or there's all that stuff that you need to sort of set it up, I just do that with lightheartedness. I'd like, even before we get started, and I get them to set down the device, like have them move themselves from a bright light source behind them, like Denise has got like a bright light source behind her, Denise Ganaza. So it makes a silhouette of her face. I can't quite see her face, not to shame you in any way for your silhouettedness. But I speak to those kinds of elements and I get them all handled. I make sure that they get the device propped up on something so that they've got their hands free. I come from a culture where I use a lot of hand stuff going on. So I really appreciate that. And then when all of that stuff is done, then I say, thank you. Now is time to begin. Simply that. I just begin after I manage all the other crazy crap that people get all wigged out and worried about. And so that's just one little trick that I think helps to own that now we're beginning. We're actually beginning to build a rapport very intentionally and very explicitly, right? So that helps just to open the door and say, okay, let's go through this door together.
And I also would add to that, I love those ideas, and would add the idea that both parties need to be in agreement about who's in the meeting. And especially when people are at home, that may change. It's pretty infrequent that someone walks into my closed doctor's room in the medical center, but it's super frequent that people just happen into a Zoom meeting who are walking down the hall and hear you yabbering, or you're in the kitchen and they're looking for a snack or whatever it is. And certainly, you know, dogs and cats are doing all sorts of funny things.
My son.
And your son, Max, exactly. And so I think that being in agreement about who it's okay to have in the room. So if I'm talking with someone and a child walks into the room, I might just ask the patient, oh, I noticed a young person or your son or daughter, whatever it is, just walked in the room. Is it okay for us to keep talking? Or what do you want to do at this point? And that also, I think, helps go towards establishing rapport, because it's about creating that trust about who's in this relationship that you are building on the video call.
Another tip that leads to is I always ask, is there somebody that I don't see who's in the room? Because quite often the spouse, the caregiver, the brother, the second cousin are sitting off screen. And unless I ask, I don't find out that they're there unless they cough or happen to get up and walk through. So it's like, so who's in the house? Where are they at? Are you comfortable with the communication? Always remember there's a whole world that you can't see. You just can see through the frame. So you have to invite them to share what they need to about the environment that they're living in. I also tend to ask people to show me if they're game, how they keep their medicines. And they pick up their device and they walk over and they show me their wheelbarrow full of medicine pills, some of them from 1845, and how they organize their medicines. It means a lot. I tend to ask people to show me if they're game with their consent. The inside of the refrigerator. It's a bit of a thing for me. I like to see what's in people's refrigerators, because that's part of what I never really thought to do it, but a couple of times in the home visits. And when I did, there was a lot there. When they talk about their garden, I ask them to show me their garden. When they've got pictures like Mike says, I ask them if they're game to share who those people are to them. And all those kinds of things are deep relationship building. And when people are acknowledged and seen as the people that they are, rather than the problems that they have, engagement, rapport, trust, it just unfolds.
So this may be the last question, and possibly the most important question of all that's been asked so far, and that is, how can you make me look 10 years younger and 10 pounds lighter on Zoom?
Oh, there's an app for that.
There is an app for that.
No, actually, in truth, one of the things that it's both an advantage and a disadvantage is that in these encounters, you have to look at yourself. Never before have you had to do that. When you've encountered a patient sitting there across the room, you've never received feedback about who you are to them. And it is a powerful feedback mechanism that has improved without me really trying too hard or learning any tips or tricks. It's having that vision of myself as I'm engaging with all of you keeps me on my toes, keeps me attentive in the frame, and it provides me with feedback about what I'm doing. When I see them respond well, I'm also aware of what I'm doing that might be a little bit better than the last time I did it. So that's, and the bad news is I don't have an app for making you 10 years younger. Or me.
Laura, see if you can ask your question.
Yeah, well, I wouldn't categorize it as a burning one, but here I am. So I wear a couple of hats. I'm a social worker in a hospice based here in Santa Monica, and I also am a music therapist in said hospice, as well as privately. You actually, what you were last talking about was a great segue, because I was just thinking about and I so appreciate the session, and I really appreciate the infusion of positivity about doing this. Obviously now currently created by necessity, but I agree. I think with our hospice, it may well continue to a degree. However, music therapy wise, I'm severely limited just because of delays and whatnot as far as doing things together. But this was already touched on, but there still is this issue with having this other person in the room when talking about really delicate, very emotionally personal, existential. I mean, this applies to other disciplines, of course, as well. When you have somebody else who's in the room with the patient because they are a technical facilitator, but they wouldn't otherwise be there, that really just does seem to pose a limitation. It's one of those ones that doesn't evaporate, I don't think, like so many of the others. I don't know if anyone has a thought about that, but
I kick people out. I get things set up and ask them to leave. When it's our staff, what I'll have them do is set up the visit and then excuse themselves. And sometimes we'll do that with family members if it seems like what's needed.
Great.
Yeah.
Hey, thank you so much. We are at the end of our time. Really appreciate your joining us. And as I mentioned, there are 4 more of these. Each one will have a slightly different theme and a different guest speaker. So keep in touch with us. Keep checking our webpage, and you'll probably get an announcement having registered for this one. So thank you all, and have a great day.
Great comments in the chat box. It was hard to keep my eyes off them. They're really interesting.
We'll get a download.
Bye-bye, everyone.